Migraine is a neurological disorder characterized by recurrent episodes of intense, pulsating head pain that often affects one side of the head and may be accompanied by nausea, sensitivity to light, sensitivity to sound, and visual disturbances known as aura. Unlike ordinary headaches, migraine attacks originate from complex interactions within the brain, particularly involving the trigeminal system, a network connecting the trigeminal nerve with the blood vessels and membranes that surround the brain. The trigeminal nerve is the primary anatomical structure responsible for migraine pain. It is the largest cranial nerve and provides sensation to much of the face, scalp, and meninges. During a migraine attack, this nerve releases inflammatory neuropeptides such as calcitonin gene-related peptide, or CGRP. These molecules trigger dilation of blood vessels in the meninges and promote inflammation around them. The brain interprets this inflammation and vascular change as severe throbbing pain. At the same time, areas in the brainstem and hypothalamus become active, influencing pain signaling, hormone balance, and sensory processing. The condition has been recognized for thousands of years. Ancient Egyptian medical papyri describe treatments for severe head pain as early as 1500 BCE. The Greek physician Hippocrates documented visual disturbances preceding headaches, a description consistent with migraine aura. In the 17th and 18th centuries, physicians believed migraine was caused primarily by abnormal dilation of cranial blood vessels. Modern neuroscience has shown that the disorder is actually neurovascular, involving both nerve signaling and vascular responses. Migraine affects hundreds of millions of people worldwide and occurs more frequently in women than in men, largely due to hormonal influences such as fluctuations in estrogen levels. Genetics also plays a significant role, with certain inherited ion channel mutations increasing susceptibility to migraine attacks. Because migraines involve multiple systems in the brain, nerve signaling pathways, neurotransmitter regulation, vascular responses, and genetic predisposition, they remain difficult to cure completely. Most treatments focus on interrupting the migraine cascade rather than eliminating the condition itself. Medical treatments include triptans, which reduce pain by constricting dilated cranial blood vessels and blocking inflammatory signals along the trigeminal nerve. Newer therapies include CGRP inhibitors that directly target the neuropeptides responsible for migraine inflammation. Preventive medications may include beta blockers, anticonvulsants, or certain antidepressants that stabilize neurological signaling. Some physical methods can temporarily reduce symptoms by influencing circulation and nerve activity. Applying ice to the back of the neck can reduce inflammation around the occipital nerves and constrict nearby blood vessels. Placing ice under the tongue cools the highly vascular sublingual region, allowing cooled blood to circulate rapidly toward the brain through major arteries. Other supportive approaches include hydration, magnesium intake, controlled breathing, and resting in a dark, quiet environment to reduce sensory stimulation. What we call migraine is not just pain, but a complex neurological cascade moving through nerves, blood vessels, and the protective membranes surrounding the brain. Treatments can interrupt the process, quieting the signals that produce the pain. Yet the precise trigger that begins this chain reaction often remains hidden. Even with modern imaging and advanced medicine, migraine continues to challenge our understanding of the brain.